Welcome to the Funnel Effect. Today, we are undertaking a really critical deep dive. We're looking into one of the most dynamic and honestly high-stakes areas in modern cardiac intervention. That's transcatheter aortic valve replacement, or TAVR. But specifically, we're focusing on that moment when Plan A, the main approach, just isn't going to work. And that forces the heart team to figure out and then execute an equally safe Plan B, which is often far more technically demanding.
Absolutely. It's a pressure situation, for sure.
Our entire analysis today, everything we're discussing, it's drawn from a brand new, really comprehensive review. It's titled Alternative Access for TAVR, a state-of-the-art review and practical guide. Just published in the prestigious JCC Cardiovascular Interventions, the 2025 edition. And I really want to take a moment here to acknowledge the incredible work behind this. There are 14 authors whose collective expertise is basically the foundation for our whole conversation today. Let me list them. Hans-Josef Feistritzer, Oliver Dumpies, Lisbeth Rassil, Darren Mailot, Toby Rogers, Daniel J. Blackman, Fadi Sawaya, Thomas Modine, Tullio Palmarini, Holger Thiel, Axel Mbahan, Kendra J. Grubb, Ola de Backer, and Mohammed Abdel Wahab. Quite a team.
That's a powerhouse list, definitely. Covers a lot of ground.
So our mission today is to kind of give you a shortcut. We want you to understand the critical decision-making process, the hierarchy involved here. We know KVR is established therapy, right? But that standard transfemoral or TF access route through the leg, it just isn't always possible. So we need to unpack the rigorous process they go through to select an alternative access route. And the focus has to be relentlessly on safety, feasibility, and, this is crucial, the specific local expertise available right there in that center to actually pull it off.
And that's where, the excitement is, but also the stress. It's intense. The last couple of decades, it's just been this dramatic, continuous shift, hasn't it? Moving away from big open heart surgeries towards these highly refined, minimally invasive techniques. Percutaneous stuff.
Right.
And that momentum, it doesn't just stop because the front door, the femoral artery in the leg is blocked. When that easy path is closed, the heart team needs a Plan B, maybe a Plan C, even D. And it has to be expertly executed, high-stakes work. The difference between success and, failure often boils down to incredibly precise anatomical planning from scans and then just flawless technique in an artery or vein that's not the usual one.
Okay, so let's start by grounding ourselves. Why do we even need these alternatives? Let's establish why the standard approach is, standard. The dominance of transfemoral TVR.
Absolutely. Good place to start. The first thing everyone needs to get is the just overwhelming dominance of the transfemoral approach. TF-TVR is the gold standard. Still is. No question. All the major guidelines, the society recommendations, and critically, pretty much all the big randomized controlled trials, PARTNER, CoreValve, Evolute studies, they all focus primarily on this access route through the leg.
And the numbers really tell that story, don't they?
Oh, they really do. If you look at the trend, the use of the transfemoral route has just skyrocketed. Back in the early days, like the PARTNER I trial, maybe around 66% TF utilization. Today, we're seeing it used in at least 85% of cases in current clinical practice globally, sometimes even higher.
Wow, that's a huge jump.
It's massive. And it reflects incredible progress, right? The delivery systems themselves are smaller now. We've got new sheath technology. And honestly, teams are just getting better, much better at managing that TF access site. Plus another factor, TVR is now offered to lower risk patients, often younger folks, and they generally have, healthier iliofemoral arteries to start with.
But like we said, the reason for this whole deep dive is that, remaining 15% or so, where that standard, seemingly easier access route is just too difficult or maybe too dangerous or sometimes completely impossible. So what's the single main barrier? What closes that femoral front door most often?
Almost every single time, the main hurdle is peripheral arterial disease. PAD. We're talking specifically about the anatomy of the iliac and femoral arteries, the pathway from the groin up. Severe calcification, hardening of the arteries, stenosis, which is narrowing, or just extreme tortuosity, really twisty vessels, trying to push a relatively large delivery system, and they're smaller, but it's still pretty big, through a path that's too narrow or too twisted or frankly too brittle from calcium. That significantly ramps up the risk of major, potentially life-threatening vascular complications.
Like what specifically?
Things like arterial dissections where the artery wall tears, aneurysms, or dislodging chunks of severe soft plaque that can then travel, embolize potentially up to the brain, causing a stroke. Really serious stuff.
So if PAD is the main enemy here, the planning phase sounds like it's absolutely paramount. It's what stops a controlled procedure from becoming a vascular catastrophe. What's the mandatory tool for assessing this risk, for creating that roadmap?
You nailed it. Pre-procedural planning isn't just like important, it's absolutely mandatory and has to be meticulous. The tool of choice, the standard, is contrast-enhanced computed tomographic angiography, CTA.
Okay, the CT scan with contrast.
Exactly. And the review really emphasizes this. The quality of that CTA is non-negotiable. It needs to be high definition, often with, say, 1 millimeter slice thickness. And it has to cover everything comprehensively, from the common femoral artery in the groin all the way up to the vessels in the head and neck.
So a really wide view.
A complete roadmap. This detail lets the heart team accurately measure vessel diameters, check the tortuosity, and, crucially, map out the precise extent and distribution of any calcium. Not just for the TF route, but also for every potential alternative route they might need to consider.
Right, you can't make that call without that high-def, 360-degree picture of the entire vascular system. Makes sense. Okay, so we've established that assessing severe PAD is key, but how do clinicians actually determine that specific objective point? When does the risk of trying to force TF access become unacceptable, really pushing them to switch to a non-standard route?
That is the million-dollar question, isn't it? It's high stakes because just relying on gut feeling, on subjective judgment, well, that introduces risk. We don't have huge randomized trials to define that line perfectly, but there is a tool that's been developed to try and standardize this complex decision. It's called the Hostel score.
The Hostel score. Okay, it definitely sounds dramatic, like you're battling bad anatomy. What are the nuts and bolts of this score? How does it work?
It's essentially a simplified scoring system. It's validated, and it's derived entirely from that pre-procedural CTA scan data we just talked about. It was designed specifically to give a quantifiable number, a characterization of how extensive and complex the PAD is in that specific patient. It looks at 7 specific anatomical variables, things like the length of the calcium, how severe it is, does it go all the way around the vessel, how twisty is the artery, what's the minimum luminal diameter, are there any old stents in the way, things like that. The final score adds up, ranging from 0 up to 39. So it gives the clinician a clear numerical value reflecting how challenging that vascular path is likely to be.
Okay, so it brings some standardization, some objectivity to what could otherwise be a gut call. And what does that number, that score, actually tell the team in practice? Is there a pivot point number?
There is. The Hostel registry work tried to nail down that ideal pivot point, and they found a statistically significant threshold right at 8.5.
8.5. Okay, that sounds important.
It's vital, because what they found was, for patients with Hostel scores of less than or equal to 8.5, the recommendation is clear. TF access, even if it needs a bit of help, some endovascular assistance, remains the overwhelming preferred approach. Stick with the leg if you're 8.5 or under.
And why is that specific score so critical? What are the clinical stakes tied to that number?
Because the registry data showed that really pushing hard to keep it transfemoral below that 8.5 threshold. That correlated with significantly better patient outcomes. Specifically, that group, the TFI 8.5 group sticking with TS, was associated with lower all-cause mortality compared to the older, more invasive surgical transthoracic approaches. And, importantly, fewer cerebrovascular events, fewer strokes, compared with other alternative transvascular accesses like going through the shoulder, the transaxillary route.
Okay, so under 8.5, you should probably try every trip in the book to keep the procedure TF, even if it means modifying the anatomy a bit. But what about those patients who score clearly above the 8.5 threshold? What happens then?
Right. When that score is greater than 8.5, meaning you're dealing with more complex, more, hostile PAD, the strategy needs an immediate rethink, usually involving the whole multidisciplinary heart team. A TF approach might still technically be possible. You might be able to physically get the sheath up, but the data suggests the risk just jumps dramatically. In those cases, attempting TF-TVR demands an exceptionally high level of expertise in complex peripheral interventions.
So specialized skills.
Exactly. If the center doesn't have operators really skilled in things like calcium modification techniques, complex wire manipulations, and if they don't have mandatory involvement of a vascular surgeon right there on the heart team for planning and for immediate backup if things go wrong, then the team really must move definitively to an alternative access route right away. The Hostel score basically helps them avoid pushing a risky TF procedure when there's likely a safer, albeit non-standard, alternative available for that patient.
You mentioned modification, using tricks to keep it TF. Let's talk about those intervention techniques, the ones designed to sort of manage that Hostel score or effectively shrink the anatomical problem so the team can still go via the leg. Because even if the anatomy looks tough, sometimes you can change it enough, right?
You absolutely can. And the real game changer here, the technology that has substantially cut down the number of patients needing alternative access in recent years, has been intravascular lithotripsy. IVL.
IVL, right, the shockwave therapy inside the artery.
Exactly that. It delivers focused shockwave energy from a catheter inside the artery, and it's specifically designed to target and fracture severe, hard circumferential calcium within the vessel wall.
So it cracks the calcium.
It literally cracks that rigid calcium shell. This makes the vessel more compliant, more flexible, allowing for the safe expansion and passage of the large-bore TAVR delivery system through a pathway that, just moments before, might have been impassable or catastrophically dangerous to navigate.
That sounds like a huge breakthrough, a technique that literally opens up these rock-hard vessels. And I remember seeing an observational study that seemed to really confirm this, showing great success rates.
Yes, exactly. That study looked at about 108 patients, all with severe PAD, and it found that IVL-assisted TF-TVR was indeed safe and, crucially, effective. It enabled the TVR valve delivery in every single case, despite that severe circumferential calcification. And they reported pretty low vascular complication rates, suggesting the outcomes were similar to patients who didn't even have significant PT to begin with. So technically, it works incredibly well.
Okay, given those fantastic feasibility results, why isn't IVL just used routinely now for every patient with challenging KPA? I understand there's some maybe conflicting registry data we need to unpack here to get the full picture of the risk-benefit.
This is a really crucial point, and it highlights why we have to be careful, exercise critical thinking, when we interpret registry data, especially observational data. While IVL technically enables success, a recent large-scale analysis, which used propensity matching to try and compare similar patients, actually provided a bit of a counter-narrative regarding safety.
Right.
This analysis suggested that IVL-assisted TF-TAVR was actually associated with higher rates of vascular complications, more surgical interventions needed, and more major bleeding compared with TF-TAVR done without IVL.
Whoa, that's a stark contrast. Higher complications. How do we square that circle?
Yeah.
Technical success, but worse outcomes. Is the IVL device itself causing problems?
Not necessarily, and probably not. The most likely interpretation, and this is highlighted by the authors of this JCC review we're discussing, is selection bias, even with sophisticated statistical matching. The patients who were selected for the IVL group probably represented an intrinsically higher burden of disease to begin with.
Yeah.
They were likely the sicker patients, the ones with more anatomically complex disease, maybe those with the really high hostile scores, where the operator felt they absolutely had to use IVL just to get the valve in.
So the higher complication rates might not be purely because of the IVL technique itself, but more a reflection of the severity of the underlying disease they were trying to treat in that group. The group was just sicker to start with.
Precisely. They were inherently sicker, had more complex anatomy than the control group, who might have only had mild or moderate PAD. So the worse outcomes, the higher bleeding, the need for surgery, are likely driven more by the severity of that underlying complex disease, not necessarily that IVL itself is inherently dangerous when used correctly. We definitely need better data to really refine patient selection for IVL, to figure out when it genuinely reduces risk versus when the anatomy is just perhaps too overwhelming even for shockwave.
And the review also mentions, just briefly, other techniques emerging in this space. It sounds like calcium modification is an evolving field.
Yes, definitely. The whole concept of vessel prep, preparing the artery before trying to deliver the valve, is gaining a lot of traction.
Yeah.
Preliminary use of things like orbital atherectomy, that's where a rotating diamond-coated crown sort of shaves or sands down the plaque, is also being explored, particularly for calcium that's maybe lopsided or sticking out into the lumen.
Yeah.
It shows that doctors are actively looking for multiple tools to make TF feasible in even the toughest vessels.
Right. More tools in the toolbox.
Exactly.
Nevertheless, the core message, the takeaway, still seems to be the clinical default, the strong preference, is still to keep it transfemoral, if at all possible.
Absolutely. The arguments favoring TF-TVR are really compelling, and they haven't fundamentally changed. Registry data consistently shows the best overall clinical outcomes with TF. It has the most practical, the most reproducible setup in the cath lab environment. Crucially, it allows for procedures to be done under local anesthesia with just conscious sedation, which minimizes risk, especially for frail elderly patients. And, maybe less discussed but important for the team, it results in less radiation exposure for the operator because they're physically standing farther away from the primary X-ray source compared to some alternatives. So yes, facilitated TF-TVR using tools like IVL when needed is still the strategy of choice, provided that detailed CTA and the hostile score assessment confirm the risk of vascular injury doesn't outweigh the known benefits of sticking with the leg versus choosing a non-thermal alternative.
Okay, let's pivot now. Let's assume the heart team has done all that homework. Meticulous CTA, calculated the hostel score, maybe even considered facilitated access with IVL, and they've definitively decided. TF access is just too high risk for this patient. We now enter that critical decision space for choosing an alternative access. What is the central kind of non-negotiable hierarchy that this source material insists the team must follow?
The hierarchy is spelled out very clearly. When TF is off the table, non-thoracic alternative transvascular access is overwhelmingly preferred. In fact, it's pretty much mandatory now over the older transthoracic access routes.
Okay, so break that down. Non-thoracic transvascular versus transthoracic.
Right. Non-thoracic transvascular means routes like transaxillary through the shoulder armpit artery, transcarotid through the neck artery, or transcaval, a special route from the vein to the aorta in the abdomen. These avoid opening the chest. Transthoracic means the older surgical approaches, transaortic, direct puncture of the aorta after opening the chest slightly, or transapical, going through the tip of the heart muscle itself, requiring a chest incision.
Okay, so we're aggressively trying to avoid cutting into the chest whenever possible. What's the fundamental reason for this strong clinical preference for the transvascular routes?
It really boils down to minimizing trauma, optimizing recovery, and ultimately improving patient outcomes. The transvascular routes are generally much less invasive. That translates to lower complication rates, lower risk of serious infections, and really importantly, faster patient recovery compared to those surgical transthoracic approaches. Those older methods require general anesthesia, being on a ventilator, and they involve higher risks of things like wound healing problems, which can be absolutely devastating for the typically frail, elderly TAVR patient population.
Yeah, that makes perfect clinical sense. Less invasion should equal better, faster recovery. But you just listed 3 different transvascular options: transaxillary, transcarotid, and transcaval. Since you mentioned there aren't large-scale head-to-head trials comparing these 3 against each other, how does a center decide which specific plan B to actually use? TAX, TC, or TCV?
And this brings us to the second major pillar, the second key factor in alternative access selection. And it's one that's often overlooked, but absolutely critical: local expertise and procedure volume.
Ah, okay. Experience matters.
Hugely. Because non-TF-TAVR volumes are inherently low at any single center. We're talking maybe only 10%, perhaps 15% of their total TAVR cases.
Yeah.
The selection of the optimal alternative route for that patient in that room on that day is primarily determined by the specific expertise of that TAVR team. The review really stresses this point. Mastering 1 or perhaps 2 alternative techniques flawlessly is far safer and preferable to attempting 3 different complex approaches infrequently. When outcomes are so dependent on subtle procedural steps, on managing potential complications instantly, focused expertise is what drives safety. You need reps.
That is such a vital takeaway for anyone listening, especially clinicians. The best route isn't just about anatomy on a scan. It's the one the operators in that specific hospital have perfected and perform regularly.
Okay, let's dive into the specifics then of these 3 preferred transvascular routes, starting with transaxillary access, or TAX, using the artery in the shoulder armpit area.
Right, transaxillary or TAX. It actually has a reasonably long history in this space, dating back to around 2008. And according to a recent European survey, it actually remains the most frequently used alternative access route among TAVI operators in Europe.
Interesting. Let's talk anatomy. Where exactly is the access point for TAX, and what are the specific unique risks tied to that location compared to, say, the lung?
Okay, the axillary artery is typically accessed in what's called its 3rd segment. Anatomically, that's lateral to the pectoralis minor muscle, sort of high up in the armpit-shoulder area.
Yeah.
This location is chosen because it offers a relatively straight shot, a reasonably direct path towards the aorta. The unique risk here, the thing everyone worries about, is its close proximity to the brachial plexus. Right, the big nerve bundle.
Exactly. That's the major bundle of nerves controlling motor function and sensation in the entire arm and hand. It runs right nearby.
That proximity sounds inherently concerning for both the patient and the operator. Seems like a very high-risk spot for nerve injury.
It logically does, yeah. However, interestingly, despite that very close anatomical relationship, severe permanent nerve injury appears to be surprisingly rare. That's true for both the surgical cut-down approach and the percutaneous needle stick approach.
How do they avoid it then?
Well, it speaks to the extreme precision required. If it's a surgical cut down, the operator uses very careful dissection to actually visualize and physically move or retract the nerve bundle away from the spot where they puncture the artery. If it's done percutaneously with just a needle, the team relies heavily on extremely precise, shallow-angle ultrasound guidance. They have to assure the needle entry point is well away from the main plexus territory, basically avoiding traversing that nerve bundle entirely. It requires skill.
Okay, so careful technique minimizes that nerve risk. Beyond the nerves, what are the key vessel requirements? What do they need to see on the CTA scan for the artery itself?
Again, pre-planning with that high-quality CTA is absolutely non-negotiable. Generally, a minimal vessel diameter of 6 millimeters is recommended for the axillary artery.
6 millimeters.
Right. That's needed to safely accommodate the TAVR sheath. Although that requirement is a bit dynamic, it depends partly on the specific size of the valve delivery system being used. Some are slightly smaller than others.
I found the note in the review about the internal mammary artery, the IMA bypass graft, particularly interesting. If a patient has had prior heart bypass surgery and has a working IMA graft coming off nearby, how does that affect using the axillary artery for TAVR?
Yeah, that's a critical technical point, a real nuance. A large TAVR sheath advanced through the axillary artery could potentially compress or block the origin of a patent IMA bypass graft.
And that would be bad.
Very bad. It could lead to significant ischemia, lack of blood flow, to the heart muscle supplied by that graft. However, the review explicitly states that having a patent IMA bypass graft is not considered a formal contraindication. You can still potentially do TAVR.
So how do they manage that risk?
It requires meticulous measurement and planning based on the CTA. The operator has to carefully measure the diameter right at the AAA origin and then deliberately position the large TAVR sheath distal to or beyond that origin point during the critical phase of valve deployment. This ensures that blood flow through the graft is maintained throughout the procedure.
Wow, that's a highly sophisticated maneuver, relying totally on perfect CTA measurements beforehand and precise sheath positioning during the case. Okay, now how is the procedure itself usually done? Is it mostly surgical or mostly percutaneous, like in the cath lab?
It's actually pretty split, and it often depends on the local expertise and tradition at that center. In European centers, based on that survey, about 65% of transaxillary TAVR is still performed via a surgical cutdown.
Okay, opening it up.
Right, often under general anesthesia. The surgeon makes a small incision, usually in the delta pectoral groove, exposes the artery directly. This allows them to close the hole in the artery, the arteriotomy, with sutures under direct visualization at the end. Gives maximum security for closure.
And what about the less invasive, fully percutaneous option, like a cath lab procedure?
The direct percutaneous technique, yeah. That accounts for about 35% of cases. It's generally preferred when it's feasible because it can often be done under just local anesthesia or conscious sedation, avoiding GA. It absolutely requires precise ultrasound guidance for the initial needle puncture. And crucially, the puncture has to be done at a very shallow angle and perfectly aligned with the axis of the vessel. This is vital to make sure that pre-closure devices work correctly.
Pre-closure devices?
Yeah, things like the suture-based Pro-style system or the plug-based Manta device. These are used to seal the hole from the inside after the big sheath comes out. But they only work reliably if that initial puncture is just right.
What's the safety net? What if those pre-closure devices fail? Or if the artery tears while they're advancing the big TAVR system?
There absolutely have to be a mandatory safety wire in place. Always. It's typically a stiff 0.018-inch wire. It's usually inserted from somewhere else, maybe the radial artery in the wrist or the brachial artery further down the arm, sometimes even up from the femoral artery in the leg. And it's advanced up into the aorta, sitting there throughout the case.
Like a lifeline.
Exactly. It's the operator's immediate lifeline. If there's an acute vascular tear or severe bleeding, they can instantly inflate a balloon over that wire to tamponade the bleeding or quickly advance a covered stent to seal the injury from the inside. It's non-negotiable backup.
Okay. So technically demanding, but feasible. While the procedural success rates sound high, what's the main headline risk? The complication we really need to worry about specifically with transaxillary access.
Right. Procedural success is generally excellent, reported between 91% and 100%. And overall, 30-day and 1-year mortality rates seem pretty similar to standard TAF access, which is good. However, TAVR has shown, in some registries, particularly early on, slightly elevated rates of major complications. Things like major vascular issues up to maybe 17%, and major bleeding reported up to 39% in some early experiences, though that's likely improved. But the biggest clinical concern that gets highlighted in the review, especially when you start comparing it to the other transvascular options like carotid or KVAL, is the potential stroke rate.
Stroke? That's interesting. Why would the stroke rate potentially be higher going through the shoulder compared to, say, the neck or the leg? That seems a bit counterintuitive.
It does seem counterintuitive, yeah.
Yeah.
But some observational studies have suggested potentially higher rates of stroke with axillary access. The numbers reported range quite a bit, maybe from 1% up to as high as 13% in some series. That's often higher than what's reported for transcarotid or transcaval access.
Any theory why?
The main hypothesis is that even with really careful technique, manipulating that large catheter and sheath in the subclavian and axillary artery region, which is anatomically quite close to the major vessels branching off to the brain like the vertebral and carotid arteries, might lead to more plaque disruption or formation of thrombus that could then embolize upwards, compared to the very short, straight path offered by going directly into the carotid artery in the neck. Now, it's important to note, propensity-matched cohorts haven't always confirmed this difference when TACS is compared directly to standard TF. But it remains a serious point of consideration, a potential downside, when choosing among the different transvascular alternatives.
Okay, so if the chest access, transthoracic, is pretty much out, and the shoulder access, transaxillary, might carry this potential, albeit debated higher stroke risk, interventionalists really needed a third, perhaps safer transvascular option. Let's talk about the route that seems to be rapidly gaining traction now, particularly in the United States. Transcarotid access, or TC. And I really want to stress for you listening, we are talking about transcarotid TC, accessing the carotid artery in the neck. This is different from transcarotid TCV, which involves the vein and aorta in the abdomen, and we'll discuss that one next. So why is this TC route, the neck artery route, suddenly becoming so popular?
Yeah, it really is skyrocketing in use. The data from the big TVT registry in the U.S. is striking. Transcarotid TVR TC accounted for about 2.1% of all TVR cases back in 2023. And maybe even more telling, it now represents over 60% of all non-TF procedures in the U.S. So when TF is an option, TC is becoming the go-to alternative for many centers.
Over 60%. Wow.
It's huge. And its popularity really stems from several clear, quite compelling anatomical and procedural advantages.
Okay, what are those key anatomical perks? What makes accessing the neck artery potentially better, overcoming that natural fear of manipulating a carotid?
Well, first and foremost, it provides a really straightforward, very short path directly from the puncture site in the neck to the aortic valve and root. Unlike the femoral route, where we constantly worry about iliac artery tortuosity, those twists and turns, in the common carotid artery, significant tortuosity is rarely encountered. It's usually a pretty straight shot.
Easier navigation, then.
Much easier navigation. This short, straight distance gives the operator excellent tactile feedback and really precise control over positioning and deploying the TAVR valve. That's a big plus. Second, the common carotid artery is easily accessible surgically. If a surgical cut down is needed for access or repair, it's a familiar territory for cardiovascular surgeons. And third, its superficial location, just under the skin of the neck, is actually a massive advantage, especially in patients who are morbidly obese. Trying to access the deep femoral artery and the groin can be technically challenging in those patients, whereas the carotid is usually much easier to get to.
Okay, that makes sense. Better control, easier surgical access if needed, better visibility maybe for closure too. But still, how can manipulating the common carotid, an artery that carries, 80% of the blood supply to that side of the brain, possibly result in stroke rates similar to just going through the leg? Aren't we just moving the risk from vascular complications in the leg to neurological complications in the head?
That is the absolutely natural concern, the first question everyone asks. But the data, so far, has provided a good degree of reassurance on stroke risk with TC. However, and this is a huge however, that reassurance hinges entirely on meticulous, absolutely rigorous patient selection beforehand.
Okay, so screening is key.
Paramount. The feasibility guidelines are strict. For the vessel itself, the common carotid's minimal luminal diameter should be at least 5 millimeters, though most experienced centers advise aiming for 7 millimeters or more to be safe with current sheaths. And you must rigorously assess for and avoid any significant calcification or especially mobile atheroma loose plaque in that target carotid artery segment that could break off and embolize during the procedure.
And the crucial exclusion criteria, the absolute no-goes, they involve the brain's backup circulation, right? The circle of Willis.
Absolutely critical. The entire cerebral circulation, the brain's blood supply network, must be thoroughly mapped out using that pre-op CTA extending up to the head. You should never, under any circumstances, attempt TC-TAVR if there is significant stenosis, meaning a blockage greater than 50% or complete occlusion of the contralateral, the opposite side's internal or common carotid arteries.
Because the brain needs that other side for backup flow.
Exactly. If you block the side you're working on, Even temporarily, the other side has to compensate fully. Additionally, the patency, the openness of the ipsilateral vertebral artery, the artery running up the back of the neck on the same side you plan to access, must not be compromised. If there's any hint of obstructive disease in the circle of Willis, the brain's central roundabout for blood flow, then advanced imaging like an MRA might be needed to definitively confirm that the collateral blood flow pathways are fully competent. If that collateral flow isn't perfect, accessing the ipsilateral carotid could indeed be catastrophic, potentially leading to permanent brain ischemia.
Wow. Okay, so this means the CTA planning for transcarotid TAVR is perhaps the most complex of all, because you're not just mapping the delivery path of the valve, you're mapping the entire brain's backup blood supply system too.
Precisely. You've hit it exactly. It transforms the procedure planning from being just a plumbing issue, a vascular intervention, into a combined neurovascular planning exercise. The stakes are incredibly high if you get the assessment wrong.
Let's delve into the procedural technique itself now, particularly regarding anesthesia and monitoring, because you mentioned this ties directly into the safety profile and those surprisingly low stroke rates.
Right. Traditionally, TC-TAVR was performed under general anesthesia, mainly because it usually involved that surgical cut-down for access and closure.
Yeah.
However, there's been a massive and really important shift in recent years towards performing it under local anesthesia with conscious sedation, keeping the patient awake, or at least lightly sedated.
Okay, what's the major benefit of keeping the patient awake when you're working on a major artery in their neck? That sounds stressful for the patient.
It might sound stressful, but the benefit is huge. It allows for real-time, dynamic, continuous neurologic monitoring by the patient themselves.
How so?
With the patient awake and cooperative, the operator can perform a crucial safety step known as cross-clamping testing.
Cross-clamping testing.
Yeah. Before committing to putting the large sheath in, they can temporarily clamp the common carotid artery for, say, 30 seconds or a minute, while constantly assessing the patient's neurological status, talking to them, checking their grip strength, watching for any signs of confusion or weakness. If the patient shows any transient ischemic symptoms, any neurological changes at all during that test clamp, the procedure is immediately aborted, or the strategy has to be fundamentally changed. You know right away they can't tolerate the occlusion. And the reviewer basing this on cited a very powerful finding that really supports this awake approach. One large study reported that the cerebrovascular events, the strokes, that occurred in their entire TC-TAVR experience happened exclusively in the patients who were done under general anesthesia.
Wow, exclusively in the GA group. That's a clinical bombshell, really. That data strongly argues for using the local anesthesia awake approach whenever possible, because the patient essentially becomes their own best real-time monitor for cerebral safety.
It really does. It provides an immediate, invaluable feedback loop that you just don't get with an anesthetized patient. The low stroke rates being reported now with TC typically ranging from about 1.6% to 5.7% in experienced hands strongly suggest that this combination of careful patient selection and the use of real-time neurologic monitoring during awake procedures has successfully mitigated much of that perceived high risk of manipulating the carotid artery.
And how does transcarotid access TC stack up when compared directly to those old, more invasive surgical transthoracic approaches?
Oh, the comparison is dramatically favorable for TC. There was a propensity-matched analysis mentioned in the review comparing TC-TAVI to the surgical transthoracic TAVI approaches. TC-TAVI showed significantly reduced rates of developing new atrial fibrillation after the procedure, much lower rates of life-threatening bleeding, and less acute kidney injury.
Better outcomes across the board, then.
Pretty much. And they also had shorter hospital stays, on average about 6 days for the TC group compared to 8 days for the transthoracic group. This just reinforces again why these transvascular access routes have become the dominant alternative strategy globally. They're just less invasive and better tolerated.
Okay, that makes a very strong case for transcarotid as a leading alternative. Now, let's move to the final preferred transvascular option. This one is perhaps the most technically exotic, maybe the most counterintuitive of the bunch. Transcaval access, or TCV. Again, just to be super clear for you listening, we are now discussing transcaval TCV. This involves accessing the abdominal aorta, the big artery, via the inferior vena cava, the big vein, creating a temporary connection. This is not transcarotid TC in the neck.
Right. Transcaval TAVR, PCV, is truly fascinating from a technical standpoint. It is a route that involves deliberately puncturing from the inferior vena cava, the IVC, directly across into the adjacent abdominal aorta, intentionally creating a temporary controlled connection, an aortocaval fistula, just long enough to advance the TAVR sheath into the aorta to deliver the valve.
Well,
And its big selling point. It is currently the only fully percutaneous, non-surgical alternative TAVR route that's associated with a stroke rate comparable to the gold standard, TF-TVR. That's a huge deal.
okay, if the technique offers such excellent clinical outcomes, particularly that remarkably low stroke risk similar to TF, why is its use, its dissemination, so limited compared to, say, transcarotid, which is taking off?
Yeah, its limited use isn't really about outcomes. It's more about the sheer technical demands of the procedure and some significant structural barriers. Firstly, there's a lack of dedicated, specifically designed on-label closure devices for sealing that hole between the aorta and vena cava afterwards. Operators have to use devices off-label, typically duct occluders designed for congenital heart defects.
Ah, okay. No dedicated tools.
Right. And secondly, and perhaps more importantly, there's a real absence of formal, widespread training programs or industry-supported proctorship for TCV. You can't just, take a weekend course and start doing this. It remains a highly specialized procedure, relying almost entirely on operators who already possess significant structural heart expertise from adjacent fields. Things like doing complex transeptal punctures using electrosurgery and experience deploying various vascular occluder devices. And critically, they need the skill set to rapidly manage potentially catastrophic bleeding complications if they occur.
Right. Sounds like it requires a very specific advanced skill set. Which patients are actually eligible for this complex route then? Who is it for?
Eligibility is actually surprisingly high, anatomically speaking. It's often considered for patients whose iliofemoral anatomy, their leg arteries, are completely prohibitive, like the ones with the absolute highest hostile scores, where even IVL isn't enough. The CTA planning for TCV focuses mainly on identifying two absolute contraindications. One is seeing uninterrupted, heavy calcium plating right on the wall of the infrarenal aorta that directly faces the IVC at the desired crossing point. You can't safely puncture through a thick plate of calcium, and you certainly couldn't close the hole afterward.
It's a soft spot.
Exactly. Need a soft, non-calcified window. The second contraindication is finding unavoidable interposed structures like loops of bowel, or maybe another artery lying directly between the vena cava and the aorta right where you need to cross. Obviously, you can't puncture through the bowel.
Okay, so the team is essentially looking for a clear, soft tissue, calcium-free window on the CTA scan to make that connection safely. Let's talk about the technical highlight, what you called the signature move, that aha moment of this technique. How do they actually cross from the low-pressure IVC vein into the high-pressure aorta safely and under control?
Right, the crossing is the core of the technique, and it uses a really sophisticated trick, electrosurgery. They use the tip of a very stiff 0.014-inch guide wire, something like an Astato XS20 wire, and they energize it with electrocautery current.
Like a boovie.
Similar principle, yeah.
Yeah.
This energized wire tip essentially creates a very controlled, cauterized tract directly across the walls of the IVC and aorta. It's a clean thermal puncture, not just a mechanical tear. This is then followed by using a telescoping system of catheters to gradually upsize that tract in exchange for a super stiff 0.035-inch wire over which the main TAVR sheath can then be advanced directly into the abdominal aorta. That electrosurgical start ensures a clean, predictable pathway.
That sounds incredibly aggressive, using cautery between major vessels, yet somehow very controlled. But then the really counterintuitive part, once the TAVR is done, the valve is deployed, and that large bore sheath is removed from the aorta and IVC. How on earth do you close a hole connecting a high-pressure artery directly to a low-pressure vein? This seems to fly in the face of everything we learn about achieving immediate hemostasis, stopping bleeding, in cardiology.
It absolutely does feel counterintuitive. Closure is definitely the most technically demanding step, and it requires the operator to accept and manage a temporary, unusual physiological state. It's typically performed using a specific type of nitinol occluder device, usually an Amplaster duct occluder one, maybe 10 or 12 millimeters in diameter, deployed from the venous side to plug the hole. But here's the key physiological insight, the genius part. These commercially available occluders are deliberately chosen because they are not immediately hemostatic. They don't instantly seal the hole completely watertight.
Wait, they don't seal it right away. Why?
Because they are designed to seal primarily by thrombosis. They provide a scaffold, and then the body's own clotting mechanisms have to form a clot on and around the device to achieve the final complete seal.
So you deliberately leave a temporary controlled leak, a small aortocaval fistula, for a short time. That seems like a massive risk for bleeding. Can you walk us through why that temporary connection is actually considered part of the safety mechanism here?
Yes, it's a controlled fistula, and managing it is key. The pressure differential between the high-pressure aorta and the low-pressure IVC is crucial. That fistula usually closes completely, thrombosis shut, within about 10 minutes or so after the operator systematically reverses the anticoagulation given during the TAVR procedure, usually using protamine. Now, here's why the temporary leak can be protective. The higher pressure in the aorta naturally pushes the blood flow into the low-pressure IVC. This actually helps to contain any initial bleeding towards the venous side, preventing it from easily escaping into the retroperitoneal space behind the vessels, which would be an uncontrolled, potentially massive bleed.
Ah, I see. The flow goes preferentially into the vein, not out into the body cavity.
Exactly. As long as the operator confirms with an angiogram, an injection of contrast dye, that any residual leak is only going from the aorta into the IVC, contained flow, and not extravasating out to the metroperitoneum, they can be reassured and proceed with careful observation while that thrombosis occurs.
But what happens if that containment fails? What if there is bleeding into the retroperitoneal space? That sounds like an emergency.
It is a potential emergency, and that's why a pre-planned, very strict bailout strategy, defined by looking at the anatomy on the CPA beforehand, is absolutely mandatory for every TCV case. This typically involves having an immediate plan for aortic balloon tamponade, having a large balloon catheter ready to inflate across the puncture site inside the aorta to temporarily stop the flow, and also having immediate readiness to deploy a covered stent graft, something like an 11 by 39 millimeter Viabond VBX stent across the aortic puncture site from within the aorta, essentially patching the hole from the inside. This is high-stakes, complex bailout work that requires specialized inventory and expertise to be available instantly.
Definitely sounds like it. So given all that complexity, what do the actual outcomes show for transcaval access TCV?
Well, despite the complexity, the success rates for delivering the TAVR valves are high and generally comparable to standard TF-TAVI in experienced centers. Early experience did report relatively high rates of blood transfusions, maybe around 35%, and major bleeding around 12%. But with refinement of the technique, particularly around anticoagulation management and closure device selection, those rates have reportedly improved significantly in more recent series. And most importantly, as we noted at the start of this section, TCV remains, currently, the only fully percutaneous non-surgical alternative TAVR route that's consistently associated with a stroke rate comparable to that of gold standard TF-TAVR. In fact, one recent comparison mentioned in the review showed that both TCV and transcarotid TAVR (TC) had similarly favorable low rates of both mortality and stroke at 1-year follow-up. But the critical caveat always remains. The excellent results reported for TCV almost always come from very high-volume, highly experienced centers, places where the operators are uniquely proficient in performing this complex procedure and in managing severe retroperitoneal bleeding if it happens. For a lower-volume center, without that dedicated expertise, attempting TCV would likely represent an unacceptable risk.
Okay, so TCV. Technically brilliant, low stroke risk, but very demanding and requires deep expertise. We've now established a pretty clear preference for these transvascular options: transcarotid, TC, transcaval, TCV, and transaxillary TACs, each with its pros and cons. Let's now quickly circle back and examine the historical surgical alternatives, the transthoracic options, and just summarize why they are, as you said earlier, fading into near obsolescence.
Yeah, it really is a stunning shift when you look at the historical data. It highlights just how fast innovation happens in this field. In the early days of TVR, maybe the late 2000s, early 2010s, these transthoracic surgical approaches, transaortic, TAO, and especially transapical TAP, actually accounted for a significant chunk of procedures, maybe up to 30% in some places.
Right, they were common alternatives then.
They were. But the relentless advances in the transvascular techniques we just discussed, coupled with the shrinking size of the TAVR devices themselves, has just decimated their usage. There was one registry analysis cited that showed transapical access, specifically going through the heart tip, fell from being used in 34.2% of TAVR cases in that registry initially, down to just 0.3% by 2019.
0.3%. It's virtually gone.
It's practically disappeared.
What are the fundamental general disadvantages that apply to all transthoracic approaches? Why the big move away?
Well, fundamentally, they are surgical procedures, even if sometimes done through smaller incisions than traditional open heart surgery. And that carries an unavoidable baseline burden. They absolutely require general anesthesia and endotracheal intubation, being on a breathing machine. For the typically frail TVR patient population, this immediately translates to higher risks. Things like hospital-acquired nosocomial infections, post-operative delirium or confusion, and sometimes serious, hard-to-heal wound complications related to the chest incision. The inherent trauma of just opening the chest wall, even partially, adds significantly to the already elevated surgical risk profile of many of these patients.
Makes sense. Let's look at the two specific routes quickly. First, transaortic, or TAO, accessing the ascending aorta directly.
Right. TA requires a surgical approach, usually either through a partial sternotomy, splitting the top part of the breastbone, or a small incision between the ribs on the right side, a mini thoracotomy. Anatomically, the team needs to find a suitable spot on the ascending aorta, ideally a 6-centimeter-long zone that's free of significant calcium, where they can safely puncture directly into the aorta and insert the sheath. It's a retrograde approach, going against blood flow towards the valve, similar to TF, but obviously through a chest incision.
And the outcomes compared to TF?
Consistently worsened studies. Compared to standard TF-TVR, TO-TVR is pretty consistently associated with higher rates of bleeding complications, higher need for blood transfusions, and also, concerningly, a higher risk of stroke.
Okay, so high risk profile for TO. Now what about the second one, transapical or TAP? Accessing the heart muscle itself at the apex or tip. This was actually the very first TVR approach ever done, right? Back in 2005.
It was. Yes, TAP was the revolutionary first approach that showed TAVR was even possible. Its main theoretical advantage, the reason it was chosen first, is anatomical. It allows for easier antegrade crossing of the diseased aortic valve. You're coming from inside the left ventricle through the heart's apex and pushing the valve down across the aortic valve, which is geometrically simpler for the catheter sometimes than fighting upstream from the aorta.
Okay, sounds simpler in theory, but what's the clinical trade-off? Why has it seen this near-total disappearance from practice?
The trade-off is crystal clear in the data. Persistently higher mortality and morbidity. Just worse outcomes. Study after study, registry after registry consistently shows that TAP-TV results in higher short-term mortality, around the procedure, and higher long-term mortality compared to TF access. It's also associated with significantly higher rates of major bleeding, higher rates of post-procedure atrial fibrillation, and much longer hospital stays compared to TF. Some analyses have even indicated that simply avoiding the thoracotomy, avoiding that chest incision, provides persistent survival benefit that lasts for years after the TAVR procedure itself. So, because of this overwhelming negative data, transapical access is now reserved only for those exceptionally rare, almost salvage-type cases where literally no other access route, femoral, axillary, carotid, or key valve, is deemed feasible by the heart team. It is truly the absolute last resort option now.
Okay, message received loud and clear. Transthoracic is out unless there's absolutely no other way in. So we've established this clear hierarchy now. TF first, ideally maybe facilitated with IVL if needed. If TF is truly out, then the transvascular options, TC, TCV, TACs, are next, with the choice strongly guided by local expertise and volume. Transthoracic is pretty much obsolete. But as you mentioned earlier, we're making these really critical, life-altering decisions based largely on registry data, observational studies, and expert consensus, not on definitive head-to-head randomized trials comparing, say, TC versus TCV versus TACs.
That absolutely remains the critical gap in the evidence base, and we have to be honest about that, acknowledge it. There are no randomized controlled trials, RCTs, comparing the different non-TF access routes directly against each other, and frankly, it's highly unlikely any will ever be planned or completed.
Why not? Wouldn't that be the best way to know for sure?
It would be ideal, but the logistics are probably insurmountable. The procedures themselves are too infrequent at any individual hospital site. They involve too many different complex techniques, different operator skill levels. Patient enrollment across multiple centers for such specific comparisons would be incredibly slow and difficult. So realistically, future decision-making in this alternative access space will continue to rely heavily on improving the quality and analysis of our observational registry data and on solidifying expert consensus through guidelines and reviews like the one we're discussing.
Okay, so given that evidence gap, what are the main driving forces that are likely to shape the future landscape of TAVR access? You alluded to this earlier by calling the overarching trend the funnel effect, this idea of constantly shrinking the number of people who even need alternative access in the first place.
Right, the funnel effect. It's a good way to think about it. And it's primarily driven by two ongoing categories of relentless technical advancements. First, and perhaps most obviously, the equipment itself just keeps getting smaller. Access sheath profiles for the TAVR delivery systems continue to decrease in diameter.
Lower profile systems.
Exactly, lower profile. This means vessels, arteries, that were previously considered marginal or just too small to accommodate the TAVR hardware are now becoming viable options for standard TF-TAVR. This factor alone removes a huge percentage of patients from needing to even consider the alternative access pool. Second, as we discussed, facilitated access techniques are rapidly expanding and improving. We talked a lot about IVL, the shockwave therapy, but the review also notes that other calcium modification technologies like orbital atherectomy are being actively investigated and used in some places. These tools are fundamentally changing the nature of the anatomical problem. They allow skilled interventionalists to safely modify heavily calcified iliofemoral arteries, essentially creating a safe passage even in vessels that looked prohibitive just a few years ago.
Okay, so if the devices keep getting smaller and the tools to clear the pathway keep getting better, one might speculate that the actual need for any alternative access might eventually decline to almost 0%.
It will certainly continue to reduce the volume drastically. I mean, it's plausible we could see the need for non-TF access drop from that current 10–15% range down to maybe 5% or even less in the coming years. But even for those remaining alternative routes that will still be necessary sometimes, we're seeing parallel advancements happening there too. For instance, innovative large-bore closure technologies are constantly being developed and refined. The review mentions things like the X-dot suture system or the percusal intraluminal patch. These new closure tools hold the promise of drastically reducing vascular complications associated with large sheath insertion across all potential access routes, femoral, axillary, maybe even making transcaval closure more reliable. This could potentially make TACS TAVR, and especially TCV TVR, even safer options when they are absolutely necessary.
Interesting. So looking forward then, within that shrinking pool of patients who still need an alternative, how do you see the competition playing out? Which specific alternative route seems best positioned for future dominance, assuming TF isn't possible?
Well, the future landscape clearly favors transvascular access over transthoracic. The demise of transaortic and transapical seems pretty much inevitable, barring very exceptional circumstances. Within that remaining transvascular domain, transcarotid access, TC, is definitely the one standing out right now as the preferred alternative for many high-volume centers, particularly in the U.S. Remember that statistic. Over 60% of all non-TF procedures in the U.S. in 2023 were TC. And that's largely driven by its advantages. That predictable, straight access path, the excellent operator control it provides, and those encouragingly low stroke rates being reported, especially when teams utilize local anesthesia and that real-time neurological monitoring. Transcaval, TCV on the other hand, offers that unique advantage of being a fully percutaneous option with similarly low stroke rates. But its extremely high technical demand and the lack of widespread training likely mean it's never going to dominate nationally in terms of volume. TCV will probably remain a highly specialized tool, primarily used at dedicated centers of excellence, reserved for patients with the absolute worst iliofemoral anatomies where even TC might not be feasible or safe.
Okay, so we have these multiple highly technical alternative options, TACS, TC, TCV, but likely diminishing patient volume needing them at individual hospital sites. Given that mismatch, what does the TAVR community as a whole need to do strategically to ensure that patients who do need these complex alternative routes receive the absolute best, safest care?
This is arguably the most important strategic takeaway point from the entire JCC review: the critical need for focused expertise and robust clinical networks. Given the inherently low volume of these alternative procedures at most individual centers, TDR programs should probably stop trying to be a jack of all trades, stop trying to offer every single alternative option infrequently. Instead, the recommendation is for centers to focus their efforts on truly mastering only one, or perhaps at most two, specific alternative access options. Whichever ones best fit their team's skill set and resources, this allows them to maintain high volume proficiency and safety in those chosen techniques.
Specialization is key.
Absolutely. The ultimate goal here has to be high-quality, reproducible safety for every patient. Therefore, developing strong regional cross-referral pathways to dedicated centers of excellence is essential. This ensures that every patient, regardless of where they might first present in the healthcare system, ultimately receives the ideal access option for their specific anatomy, whether that's TF or facilitated TF or transcarotid or maybe even transcaval, and that it's expertly performed by a team that does that specific procedure frequently and maintains flawless technique. That deep, focused, high-volume expertise is simply non-negotiable for managing these complex alternative access cases successfully and safely.
That makes perfect sense. Build networks, focus expertise. Okay, that brings us towards our final synthesis for today's deep dive. What we've really underscored today is a clear and still evolving paradigm in how TAVR is approached when the standard route isn't available. While transfemoral access absolutely remains the ultimate goal, and it's now often achievable even in challenging anatomies thanks to sophisticated facilitation techniques like intravascular lithotripsy, when that femoral route is definitively impossible or too risky, the modern transvascular alternatives are overwhelmingly preferred. These options, transcarotid, transcaval, and transaxillary, offer dramatically better clinical outcomes, significantly lower morbidity, and much faster recovery compared to the older surgical transthoracic routes like transaortic and transapical, which are rightly fading away. The absolute key to success in this alternative access realm rests entirely on two pillars. First, that meticulous, comprehensive anatomical assessment using high-quality CTA, potentially utilizing risk stratification tools like the Hostel score. And second, the absolute necessity of selecting not just the right anatomical route, but the right team. A team with deep, focused, high-volume expertise in performing that chosen alternative procedure. Whether it's the relatively straightforward path of transcarotid or the incredibly technically demanding percutaneous route of transcaval. And finally, as always, a provocative thought for you, our listener, to consider as you digest all this. We've seen how IVL has dramatically expanded the feasibility of standard TF access, kind of taming hostile anatomy. If technical advancements continue at this pace in adjacent fields, specifically thinking about even more sophisticated atherectomy tools perhaps, or revolutionary new large-bore closure devices that might drastically shrink the necessary sheath size or make closing large punctures trivial, will these innovations eventually make any alternative TVR access completely unnecessary? Could we reach a point where TF, perhaps always facilitated, works for literally everyone, reducing the need for alternatives to a true zero? Or, perhaps counterintuitively, will these advancements simply make the remaining alternative procedures, like maybe transcaval TVR, so safe, so simple, and so reliable that they might actually start to replace TF in certain specific patient populations, not out of necessity, but because they offer superior anatomical control or even better niche outcomes? Something to think about. Thank you for watching The Funnel Effect.